afternoon and welcome to the Maine Health Management Coalition's webinar today on the financial benefit and legal guidelines of a successful wellness program. My name is Marie Stuckey and I'm the Member Relations Specialist here. And I am going to just go over a few pieces of business for our members and a little overview about the coalition for those joining us who are not familiar with us. And I want to say a thank you to our presenters today, Dr. Stephen Noeldner from Mercer and Christopher Lockman from Dana, who will be sharing their expertise. We really appreciate their time today. So just as some background about the coalition, we are a multi-stakeholder collaborative led by employers, but we do have 5 different membership categories. So in addition to employers, we have consumer organizations, one group of health plans, brokers, and benefits consultants, providers who give care, and then affiliate organizations who also support our mission, which is to improve the value of health and maximize that value of healthcare in the state of Maine. The way we do this is through 5 key initiatives, the foundation of which is through our data department, which houses all the state's health benefit claims. And with that, we can do a lot of benchmarking and reporting to help employers and providers understand the costs and associated with those benefits and where the drivers are of cost. We also have a group that works on transparency by publicly reporting the outcome, safety, patient experience, and costs of care for adults and children, and that's on our website, Get Better Maine, so please check that out if you are not familiar with it. We support our members by helping them engage with their employees through a variety of ways. In the past, we've done book clubs and competitive programs, and we provide them with resources on information to help them as well. We also make recommendations working closely with health plans on benefit design to ensure high-quality patient-centered care. And finally, we also work on payment reform, working closely with hospitals and systems. We do things such as look at alternative payment arrangements. So that's how we achieve our goals. And just as background, some great upcoming meetings you should be aware of. Our healthcare costs work group will be meeting on May 26th. You see the information right there. If you are a new member or a member who'd like other people in your organization to know more about us, please join us on June 3rd for our orientation breakfast. And finally, we're very excited to have a forum on health benefit trends on June 16th. It will include a networking lunch. We'll go over data trends and have a very robust panel discussion of which Mercer is participating. So how do members optimize their membership value here? Well, there's many ways to do that. We help them to identify best practices in health plan design and workplace wellness. Again, through our data department, we provide custom analytics so they can make smart business decisions. We help guide their staff to high quality, reasonably priced healthcare through some of the transparency efforts that we do. Being part of the organization certainly brands our members in support of Maine's healthcare value and economy and helps recruit talented staff for them. It's a great networking opportunity to be a member of the coalition. We get great connections going between all our events. And we do have lots of activity in our work groups and committees that can help influence change in the state. Finally, we also offer our members complimentary registration to our symposium. They get our newsletter, webcasts such as this, and all our different learning events. They also get discounts on certain health-related products and services. This slide just shows you some of our great members, the logos for them. And with that, I will go ahead and introduce our first speaker today. Dr. Stephen Noeldner is a partner and senior consultant in the Total Health Management Specialty Practice at Mercer Health and Benefits. He is a national resource and expert in the areas of strategic planning, program design, behavior change, and program evaluation. Dr. Noeldner is the chair of HERO's Research Studies Subcommittee. He is also a co-author of the HERO Health and Wellbeing Best Practices Scorecard in collaboration with Mercer. He has over 30 years of in the health and well-being industry, including clinical practice in cardiac and pulmonary rehabilitation, hospital administration, university teaching, research, well-being program management, and serving as president of a well-being provider company and consulting. Stephen's education includes a Ph.D. in exercise science with concentrations in sports psychology, cardiovascular physiology, and biomechanics, and a MS in adult fitness and cardiac rehabilitation. He is certified by the American College of Sports Medicine as a program director, and he has written and published numerous papers, book chapters, and served as a peer reviewer for several professional journals. So we welcome Stephen. And then we will also be hearing from Christopher Lockman, who is joining us from Dana. He's an associate in the Employee Benefits and Executive Compensation Group. They're based in Portland, Maine. Chris works with employers on a wide variety of employee benefits matters involving retirement plans, health plans, wellness programs, reimbursement programs, and related legal compliance issues. Chris is a frequent speaker on Affordable Care Act legal compliance issues, including issues presented by consumer-driven health plan designs, and is a regular contributor to Dana's Employee Benefits and Executive Compensation Group blog, which you see the address for right there. So with that, we will pass the controls over to Dr. Noeldner, who will speak first. And if you think of questions anytime, please put them in the chat box, and we will answer them at the end of the presentation. Dr. Noeldner?
Thank you, Marie. I am delighted to be here today with all of you, and in a sense, it's somewhat like speaking to the choir, because I know that you're all committed to health management and the value of health management, well-being for your employees and your organizations. So it's a delight to be here today to talk with you. As you heard from the title of today's webinar, we're going to focus on some of the value proposition for well-being programs and health management programs. And by the way, I'm delighted to be here with Chris as well, who has some hot topics. As you know, the EEOC final regulations came out last week, so he'll have a lot to talk about, and what we'll discuss today will certainly be synergistic. I'm delighted to talk about a study that I was recently a co-author of that helped to set the stage and frame the value proposition for well-being in a slightly different way than has been done in the past. And that is where we undertook a study to look at the stock performance of organizations that had very substantial well-being programs and compared those to performance of the stock market as a whole, as indicated by the Standard & Poor's 500 index. You heard reference in Marie's introduction of my association with the HERO scorecard. For those of you who aren't familiar with HERO, HERO is an acronym for the Health Enhancement Research Organization, a not-for-profit organization that is dedicated to identifying and supporting and promoting best practices in employee health and well-being programs. This scorecard that Mercer and HERO developed jointly and launched a number of years ago is one of the instruments that we use to identify best practices. And I'm going to tell you more about the scorecard later. It's a free instrument that anybody can use, and I'll give you more details about how to use it yourself. For now, I'll just talk about how we use the scorecard. So once someone completes the scorecard, an inventory of best practices, a total score is generated, and we use top scorers who are also publicly traded companies to develop a portfolio for investment tracking purposes. And we tracked it for 6 years, as you can see in the graph, and compared the results of the Hero Scorecard Best High Scores portfolio to the Standard & Poor's 500 index. And you can see that over those 6 years, the high-scoring well-being organizations outperformed the Standard & Poor's 500 index by about 50%, which is pretty substantial. Just to show you that we did all we could to try to control for possible other explanations for what that financial results that the companies realized. And by the way, I should say at this point that we're not suggesting that this was cause and effect. The study design didn't allow us to tell us that these companies had high-performing stock value because they had well-being programs, but there's an association or a correlation there. And I'm going to show you some ways that we tried to control for other explanations for that and some other studies that came up with similar results. So you can see in this slide that we looked at 45 different publicly traded companies ranging in size from 760 or so employees to over 270,000 employees. They look like organizations that are typical around the country. 43 years of age is the average age of employees and 56% male population. Covered 8 different industries, as you see in the lower right-hand side. So well represented by different companies in different sectors of the economy. In addition to their stock price outperforming Standard & Poor's 500, their dividend performance outpaced the Standard & Poor's 500 companies as well. And on the upper right-hand side, you can see that it wasn't just 1 or 2 quarters of extraordinary growth that distinguished the Hero Scorecard companies from the Standard & Poor's 500 companies, but quite consistent outperformance 16 out of the 24 quarters of the study that were tracked. So pretty exciting results. And to corroborate that, we had some similar studies, some related studies, and you can see that there's some shared authorship in across some of these studies as well. But we wanted to use a similar methodology and look at some other portfolio groups. So on this graph, you can see that another comparative group was the C. Everett Koop Award winners. And you probably are well aware that the C. Everett Koop is probably the most prestigious award in the health and well-being space. It's a rigorous evaluation, and outcomes are required to be reported. So these truly are companies that exhibit best practices and have many best practices in place for a number of years. The other comparator group is the Corporate Health Achievement Award, conferred by the American College of Occupational and Environmental Medicine. They also give an award for substantial well-being programs. They have another award for organizations that have both substantial well-being and safety programs. You can see that we have a longer timeline for the Koop and the Corporate Health Achievement Award studies, and the portfolio of those organizations stretches for 14 years. And we saw similar results. Those organizations, or the portfolio companies in those organizations, top winners and award winners, outperformed the Standard & Poor's 500 by up to 200% for the Corporate Health Achievement Award winner over the course of 14 years. So what does all this mean in a real and practical sense? Well, these studies, and certainly the fact that there are multiple studies that looked at slightly different groups, there was some overlap in some of the companies winning some of the same awards. But in general, different groups compared over different periods of time, coming up with essentially the same result, that there was an association or correlation with best practices in employee health and well-being and stock performance in the publicly traded stock market. This contributes to the growing evidence that there is a link, or maybe a link, or at least an association between employee well-being and company performance. And I think if we go down to the lower left-hand quadrant, it helps us broaden the definition and broaden the view of the return or the value of programs that we offer in the well-being space. You've probably had senior leaders in the organizations or colleagues ask, what's the return on investment for well-being? And as you know, it's a bit challenging to measure that alone. And it is indeed only one element, we believe, of the whole value story for employee health and well-being. So we're now moving this up, we think, to the senior leadership and the C-suite of the organization and saying, there's a good likelihood that having a well and healthy workforce is helping your business become as good as it can be, financially and in business performance as well. Not to mention that there's evidence that healthy and well-being and people who experience great well-being also perform better on the job, are more engaged in the job, and do, in fact, have lower healthcare costs. Again, I think it's important to recognize that well-being programs are maybe just one of multiple superior business practices that lead to businesses' exceptional financial performance, but probably an important one. And again, the HERO scorecard demonstrates its utility as being able to distinguish best practice programs and those that have some impact on the organization's business practices as well. So that's some background. I just want to take a moment to focus on a slide to talk about some best practices, but that's also why I'm going to introduce to those of you who haven't heard of the HERO scorecard before a little bit more about it and how you can access it and use it free of charge to build a best practice program or check to see if your current health and well-being program is at a best practice level. But this slide sort of lays out some of the areas that we're seeing in the evolution from what has traditionally been a focus on physical well-being, physical wellness, physical health, to broadening that to include other areas in a broader definition of what we're calling well-being. Again, for those of you who've been around, you know that term isn't new, and it has had a number of definitions and still will have a number of definitions. But the point is that we're seeing a broadening of the focus and breadth of programs around health and wellness. And they're now including emotional, financial, social elements as well. And you can see the different activities that we're seeing stacked under those different topics, those broad categories. Just a brief moment on financial well-being. The reason that that is becoming a very important area of focus for many organizations is that we know that it's been reported and demonstrated in the research literature that up to 60% of distress that individuals experience is related to financial concerns. So if an organization can provide more support around an individual's financial well-being and their understanding of how to navigate the world of finances for themselves and their family, that could help reduce stress in their lives. So some core elements of best practices that we know are very, very important. One of them is to commit to a culture of well-being, and that really means that from the top down, the bottom up, and everywhere in between, the organization doesn't just express in words, but shows by their actions that they support the culture of well-being. So it's acceptable to be focused on exercise and good eating. It's acceptable to take care of behavioral health issues if I have them. If I have a chronic condition and it's not well managed, it's acceptable and desirable to engage with a care management nurse through that program through my carrier. So the culture is really the glue that brings it all together and probably magnifies the benefit of any one or multiple efforts within a health and well-being program. Another one is creating an exceptional member experience. We know that many people who've been involved in different aspects of wellness and well-being programs over the years have had so-so experiences. And I'm going to pick on, just for the sake of an example that I've seen a number of times, coaching experience, whether it be with a lifestyle coach on a telephonic basis or telephonically with a care management, disease management nurse. And as you probably are aware, oftentimes there's an outreach process by letter and then perhaps by phone to try to get someone on the phone to talk to you about your health risks or your chronic conditions. And then the first call is all about getting patient history and repeating everything that you do every time you go to a new doctor and putting down your medical history. And at the end of that call, the participant may agree to schedule another call, but going away from that call, they'll say, well, there wasn't much in that call for me. Why did I do that? Instead of an approach where somebody in the very first encounter with any program, I'm picking on coaching right now, but in the very first encounter and everyone after that, the member has a delightful experience. They took something away that they could actually use today, right now, an action item that's going to improve their life. That's the kind of experience, the exceptional experience that needs to be the norm rather than the exception in well-being programs. As well, it's important that programs are focused on supporting long-term behavior change. Say one thing that I see often in companies, and certainly in new companies or new well-being programs, I should say, it's probably understandable and maybe not a bad idea to focus on awareness to begin with, awareness created by taking health assessments and maybe biometric screenings, helping people get in touch with their health risks and health conditions. But if that's the only focus of the well-being program year after year, and there's an incentive attached to that and that alone, that's probably not going to influence long-term behavior change. A lot of people don't act on their awareness. They need some support systems and some ways to get involved. So developing a well-being program that supports people along the way continuously to change their habitual habits is the ideal. And then finally, establishing clear measures. I used to say you wouldn't leave home without a map if you were going to a place you didn't know. And now maps are pretty much obsolete, so now I'll say you wouldn't leave home without a GPS device and an address at the other end to have some guidance how to get there and know where you're going. And clearly the same is true with your well-being program. You really should have a written strategic plan, ideally a multiple year plan, and some specific targets for participation, impact of those programs, and outcomes as well. And by the way, I know that was very quick. We do expect to have some time at the end of the session to talk in questions and answers. And if you have specific questions, you can certainly reach out to me after the session as well. Now, very briefly, an introduction to the HERO scorecard, which I've alluded to before, and some will be a bit redundant, so I will keep this relatively quick. The history you can see launched in 2009 as an online version. We in fact did a validation study in 2013 published in the Journal of Occupational and Environmental Medicine that showed that HERO scorecard high scores had a minus 1.6% healthcare cost trend over 3 years. So that's a pretty substantial and pretty exciting outcome for organizations that have best practice programs in place. The current version of the HERO scorecard has 6 sections in it. You can see the areas that are covered. And when you complete the online HERO scorecard, there will be questions in each of those areas. And at the end, when you press submit, you'll get an instantaneous email with a score for both the total score for your scorecard as well as score for each of the sections and national benchmarks that you can compare them against. And why would you want to do this? Well, the scorecard certainly contains an inventory of best practices. So if you're just starting out, and by the way, it's well adapted to organizations of any size, the benchmarking data and the representation in the database right now is almost equally distributed across all employer sizes. So good to know that even if you're a very small business or if you're a very large business, the scorecard is relevant for you. Beyond understanding how to start a program and what best practices are or what best practices you could incorporate into your maturing program, by completing the HERO scorecard on multiple occasions over the course of time, you can also track your program's progress and success. Another really valuable point, I think, is that when you sit down to complete the scorecard, and by the way, you'll see in the next slide make reference to the fact that in addition to a link to the online scorecard, that same link will also provide access to a PDF version of the scorecard. So you can literally print out the scorecard in advance, gather a few stakeholders or interested parties from your organization, come to consensus on the answers to each of the questions. Then one person inputs those results into the scorecard online. You'll get your results back, and then it would be advisable to sit down again with your colleagues and say, okay, now what does this mean to us and how are we going to use it? So you can use it from a comparative benchmarking tool and also as a planning tool going into the future. And here's how it works. I think I've already covered most of these points. I've provided a link to the HERO's website, the HERO website that has both that PDF version and the actual link to the scorecard. I'll briefly mention that you also see reference to preferred providers. Mercer is a collaborator and a preferred provider as well. There are about 8 or 9 other organizations, some of them healthcare organizations, others wellness vendors, and they use the scorecard as well to work with their clients. And the reason that that may be a benefit to you if you work with one of those preferred providers is that those preferred providers have access to additional benchmarking information. So with that, I'm going to turn it over to Chris, and we'll talk to you at the end if we have time for questions and answers. Thank you.
Thank you so much, Dr. Noeldner. And I just want to remind people to go ahead and at any time put their questions in the chat box as we go over through our broadcast, and we'll address them at the end. So Chris, you have the controls and are all set to go.
Great, thank you very much, Marie. My name is Chris Lockman, as was mentioned earlier, and I'm going to talk about one aspect of a well-being program, which are the more conventional wellness programs that focus on the physical well-being of employees. My presentation will also focus on sort of where the rubber meets the road in terms of requirements for and regulations that surround these types of programs. So I will talk initially about the HIPAA final wellness regulations, because the terminology is consistent between those regulations and the new regulations that were just released last week by the EEOC. And then I'll get into the ADA and GINA regulations released by the EEOC just last week, briefly. And there's more information about the new regulations available on our blog website at employeebenefitsupdate.com. In addition, I'm happy to answer any questions that you have at the end of the presentation or offline if you want to send them to me via email. So we'll get going. So the first real issue is basically a description of why we have these regulations and what their focus is. Now, HIPAA generally prohibits group health plans and health insurance issuers from discriminating on the basis of health factors. And health factors are things such as an employee's disability, an employee's medical conditions, or claims experience, among other things. Wellness programs that fall within the final HIPAA rules have an affirmative defense to a claim that an employee was discriminated against by an employer's wellness program. There are 2 types of wellness programs that are identified in the final HIPAA rules, which have been around since 2006 and were revised in 2013 to basically square with provisions in the Affordable Care Act. The 2 types of programs are participatory wellness programs and health contingent wellness programs. Participatory wellness programs are programs that either do not provide a reward to employees for participating or do not have any conditions for receiving a reward that are based on a health factor, medical condition. Participatory programs include health risk assessments, so these questionnaires that provide a reward just for completing the assessment and don't provide a reward based on responses or outcomes. The final HIPAA regulations are pretty loose when it comes to requirements for participatory programs. Essentially, participation must just be available to all similarly situated individuals. This doesn't mean it has to be the same for every employee. Your availability of the program may differ based on a bona fide employment-based classification or on which insurance coverage an employee has. The second type of wellness programs, and certainly the most popular and more aggressive designs, are health contingent wellness programs. And those are programs that require individuals to achieve a health outcome or meet a health-related standard to get a reward. And those fall into two subtypes or subcategories. The first type or category is an activity-only wellness program that requires an individual to perform or complete an activity related to a health factor. These are programs that are walking programs, diet programs, exercise programs. They differ from participatory programs in that participatory programs don't involve a health factor. Basically, they're reimbursements for gym membership and those types of things. Activity programs may not be appropriate for certain members of your employee population. For instance, someone who had a recent knee surgery may not be able to participate in an activity-only walking program. The second type are outcome-based programs, and these are the programs that require individuals to attain a specific health outcome in order to obtain a reward. So you have a biometric screening system that looks at body mass index, cholesterol level, blood sugar level, and you provide an incentive or reward for employees that meet certain metrics. If your BMI is below 30, let's say, you get a premium reduction or some other reward or benefit. Health contingent programs have several requirements under the final HIPAA rules. The first is that they must be reasonably designed to promote health or prevent disease. They can't be a cover for discriminating against all of your tobacco using or overweight employees. Employees must be able to qualify for reward at least once per year. And financial rewards are not permitted to exceed certain limits. And this has to do with how voluntary participation in the program really is. If it's a reward available under the program is extremely large, it's not a particularly voluntary program. I'll talk about these for just a moment because this is one of the areas where there are differences between the final HIPAA regulations and the new EEOC regulations under the ADA and GINA. So the maximum reward that's available under the final HIPAA rules is 30% of the total cost of coverage in which an employee is enrolled, meaning if they have self-only coverage, it's 30% of that coverage. If they have family coverage and a family member is allowed to participate in the program, for instance, the spouse fills out or a questionnaire or engages in biometric screening, it can be 30% of the total cost of that coverage. What I mean by total cost is the cost both to the employee and the employer, not just 30% of the cost of premiums paid by the employee. In 2013, the final rule was modified to allow rewards up to 50% of the total cost of coverage for programs that target tobacco use. And this has to do with an ACA provision under the Affordable Care Act. Finally, the programs must also be available to all similarly situated individuals. This means the same thing that it does for participatory programs, but there's an added element in that you must offer reasonable alternatives for people who may not be able to meet a specific requirement of a program or participate in an activity-only program. Stated differently, you must provide some means of accessing the reward available under the program for individuals who don't meet your initial program requirements. For activity-only programs, you must allow a reasonable alternative standard if it would be unreasonably difficult or medically inadvisable for an employee to satisfy one of the criterion or participate in the activity. You may request physician verification that it's inadvisable for the employee to participate at the first level. However, you do need to provide some type of alternative. You don't have to say up front what the alternative is or identify it, but you must make participants aware that a reasonable alternative is available if they ask for one, and all of your plan materials must disclose the availability of that reasonable alternative. The reasonable alternative requirement is a little different for outcome-based programs. Basically, you have to offer a reasonable alternative to individuals who do not meet the standard out of the gate without any request for a doctor's note or some other verification or justification for why they cannot meet the initial standard. For example, back to body mass index. If you have somebody who has a body mass index in excess of 30, and you only provide a $100 premium reduction to individuals who have BMI below 30, you must provide a reasonable alternative if the individual requests one. That alternative for outcome-based programs is typically participation in an activity-only program. So if your BMI is too high, you can participate in a weight loss or exercise regimen, or attend nutrition counseling, or do something else and receive the same reward. As a second level, you must accommodate the recommendations of the individual's physician. So if your reasonable alternative is offered, the employee does not feel they want to participate in that reasonable alternative, you must accommodate recommendations of that individual's physician as a second reasonable alternative. We just talked a lot about the requirements for these types of programs, and if you have a program design that fits in and satisfies all of these requirements, you are protected or have an affirmative defense to a lawsuit that you discriminated under HIPAA. You do not, however, have any defense to a claim that you discriminated under some other portion of the law, specifically the Americans with Disabilities Act and the Genetic Information and Non-Discrimination Act. That's been the focus of EEOC attention in the last 2 years. So basically, the ADA prohibits medical exams unless they are job-related and consistent with a business necessity. There are 2 exceptions to this prohibition. One exists for terms of bona fide benefit plans, and one exists for voluntary wellness plans, and we'll talk about what voluntary means in a minute. In addition, GINA generally precludes or prevents employers from requesting genetic information that concerns an employee or an employee's family, and also prevents employers from using that information. There's another exception under GINA for voluntary wellness exams or programs. Both of these prohibitions and the exceptions are contained in the statute. What we didn't know until very recently was how these are to apply in our wellness programs, or the sort of physical well-being portion of our wellness programs. And despite requests from employers and employee groups, the EEOC had not released any rules about what was a quote-unquote voluntary program under the ADA or under GINA. Unfortunately, in 2014, without releasing any rules, the EEOC initiated litigation against 3 different employers who sponsored wellness programs. It was actually the same regional office, district office of the EEOC based in Chicago, and each of these lawsuits alleged that the employer's program discriminated under the ADA and GINA. Of particular concern was the Honeywell case, the last lawsuit initiated, because that looked similar to a lot of existing wellness program designs, and for the most part complied with the HIPAA final wellness regulations. So, you know, the thought that complying with the HIPAA regulations would provide some protection under the ADA and GINA was sort of torn back from employers at that point. People complained. They complained loudly. Employers complained, Congress complained, the Obama administration indirectly complained that these were gotcha lawsuits, that without releasing rules, the EEOC went after employers who were sponsoring wellness programs. Perhaps in response to those complaints, the EEOC released proposed regulations in 2015 that talked about what was voluntary under the ADA and what would fit within the GINA exception to the prohibition on requesting genetic information. Those rules were just finalized on Monday of last week. Basically, the ADA rules affect only programs that contain disability-related inquiries or medical exams and focus primarily on what constitutes a voluntary wellness program that is accepted from the ADA prohibition. The final GINA rules talk about what incentives are permitted for a spouse's participation in a program, and also talk about limitations that apply that prevent employers from collecting genetic information that concerns their children. I want to focus here on just sort of two pieces of this table because these rules are new, and so I want to get to the highlights on the next slide. Basically, there are differences in the incentives that are available under the HIPAA final wellness rules and under the EEOC's final ADA rule and final GINA rule. So we talked before about how the HIPAA rule allows 30%, a reward that's up to 30% of the cost of coverage in which you're enrolled. The final ADA rule limits this incentive to 30% of the cost of self-only coverage. For some employers, that's a significant difference. Fortunately, the final GINA rule allows an additional incentive up to 30% of self-only coverage to incentivize or induce spousal participation. So in some cases, you may actually have a more generous incentive or inducement available for spousal participation under the ADA rule than under the HIPAA rule, depending upon the cost of coverage. However, it's important that we try to comply with all three sets of rules, and as a result, need to sort of design our programs to fit within the lesser of either incentive. The second or the third row down talks about the differences for tobacco. There's a special incentive allowed up to 50% of the cost of coverage under HIPAA for programs designed to target tobacco use. That same incentive is not allowed under the final ADA rules, and if the program includes a disability-related inquiry or medical exam, it's important to note a simple questionnaire is not considered about tobacco use is not considered a disability-related inquiry. But if you're testing for tobacco, your program benefit will be limited to 30% of the total cost of self-only coverage. People tend to focus in on what these allowed limits are, and there's a lot among lawyers and other folks who worry about compliance, and a lot of stink made about the difference between the incentives. But just so you know, the average incentives available in the Maine market, in New Hampshire as well, tend to range between 10 and 15% of coverage. There are some that are more aggressive. There are a few that offer far less than 10% of an incentive, but most programs are not close to these limits. It's just important that you recognize there's a difference between the limits in the two sets of rules. So what are the highlights from the final rule released by the EEOC? The first one actually goes back to a sort of foundational requirement in the HIPAA final rules, which is that the program must be reasonably designed to promote health or prevent disease. The ADA and GINA rules make it clear that in order to be reasonably designed, if your program is collecting information about your employee participants, you must utilize that information. The program must utilize that information in a way that provides some type of feedback information or programming that addresses some of the conditions identified that are negatively impacting your employee population. That's an important foundational requirement and something that's not you don't want to lose sight of. As Dr. Noeldner mentioned, I mean, at the end of the day, this is all about encouraging employee wellness to encourage employee productivity and ultimately profitability. The second requirement is there's a specific prohibition in the ADA and GINA rules against gateway programs. This was an issue that was not addressed in the final HIPAA rules, but what gateway programs are designs that prohibit or prevent employees who do not participate in the wellness program or satisfy a particular metric of the wellness program from enjoying the same benefit options as other employees. These gateway programs are not permitted or forbidden under the ADA rule. The phrase manifestation of disease or disorder is introduced in the final GINA rule, and that phrase replaces the phrase current health status used in the proposed rule. So to take a step back, you recall, and most of you know, that only genetic information is covered by GINA. There was some critique about the limitations in the proposed rule because several practitioners thought that it went beyond the scope, the rule went beyond the scope of GINA by limiting incentives available in exchange for health information about an employee's spouse. The rule was revised to focus on information concerning the manifestation of a disease or disorder in an employee or an employee's spouse, and that's a subset of genetic information for which an incentive can be offered, subject to the limits that we discussed on the prior slide. New notice requirement. There is a new notice requirement under the final ADA rule that you must provide notice to participants who will participate in your wellness program that's clearly written about what medical information will be obtained through the program, who will receive that information, how it will be used, and the restrictions on disclosure for that type of information. The EEOC has promised to release a template notice within 30 days on its website. So you can check the EEOC website for that information. In addition, this isn't a new requirement, it's an existing requirement under GINA, but to the extent that genetic information is requested of an employee or an employee's spouse, and that includes this manifestation of disease or disorder information, the individual providing the information must provide a knowing, written, and voluntary authorization for disclosure of the information, and the authorization form must describe the confidentiality protections that will apply to information that's collected. And finally, confidentiality protections. This may be old hat for a lot of you, particularly in the medical field, but you have to think about the chain of custody for information that's collected through your wellness program and ensure it's being handled in an appropriate manner. So if your wellness program is part of your group health plan, the HIPAA privacy rule applies, and so all of the requirements about firewall and plan amendments and so on apply. You need to think about if your wellness program is included as part of your HIPAA privacy policy. If it's not, if your wellness program is not part of your group health plan, there are still requirements that apply, and basically the limitation is that only general aggregate de-identified information may be passed back through to an employer, and that information cannot be reasonably likely to be identified on an individual basis. So I mentioned before this bona fide benefit plan exception. That is one of the unsettled areas in this type of law. So if you recall, I mentioned there are two exceptions to the ADA prohibition on medical exams or questionnaires. One of the exceptions states that under the ADA, a program, the ADA cannot be construed to prohibit or restrict employers or other covered entities from establishing or administering the terms of a bona fide benefit plan that are based on underwriting risks and classifying risks and so on. So basically, there are two court decisions that have decided that wellness programs are a means of collecting information that can be covered under this bona fide benefit plan safe harbor if they're a term of a group health plan. The EEOC has consistently rejected this read of the statute, and in fact, in the final rules, takes a stand, says it will not recognize the bona fide benefit plan exception, and also makes the statement that it believes the federal courts were wrong. Currently, the EEOC v. Flambeau case where this issue is being litigated is on appeal before the U.S. Court of Appeals for the 7th Circuit. We'll see how that shakes out, hopefully soon. So just in closing, before we get to questions, and I know we're running low on time as it is, there are some tips and takeaways even though the law is not entirely settled. The first one, and I can't overstate this, is make the program as voluntary as possible. If your employees believe that you are trying to help them lead better and healthier lives, they're much more likely to engage the program in a positive way than if it's couched as a penalty for people who smoke or don't exercise or don't attend the nutrition course, that type of thing. As part of this, if you have a program that doesn't base cost differences on outcomes, so you have a program that's not an outcome-based program, rather you incentivize employee education and other things, not only will your employees perhaps feel more engaged or less threatened by the program, but it's likely to escape EEOC scrutiny. If the program is outcome-based, provide reasonable alternatives. Tell people you're providing reasonable alternatives, and make sure that your incentives are within the allowed HIPAA and ADA limits. There's a question, and this is the second bullet: incorporate the program into your health plan. There are several reasons why you may still want to incorporate the program as part of your health plan, even though the bona fide benefit plan exception issue is not yet settled by the courts. But there are several reasons why you may not want to. For instance, you may want to allow employees who are not group health plan employees to participate in the wellness program. So that's an issue that will be is something that's important and will benefit some employers, and yet is not preferred for other designs. Finally, the last two, and really critically important pieces, are provide clear employee and spouse communications about the program, what it is, what you're seeking, and make sure that your communications are consistent and they align with the requirements under the rules. And then finally, assure privacy and security. We just talked about this. Know what information is being collected and know what the flow of that information is. That is all that I have for right now. As I mentioned before, I'm happy to take questions or answer questions offline after the program.
Thank you so much, Chris, and thank you also, Dr. Noeldner. So now is the time, if you haven't already and would like to put some questions in the chat box, and I will relay them to our presenters. So the first question I do have is for Chris, and it says, that is 30% of total cost of coverage if you are enrolled with a spouse. You had said that, but is that only if your spouse also has the opportunity to participate?
That's correct. So if you're it's a little difficult to explain sort of the math around these rules, but under the HIPAA rules, basically it's 30%. If you're only allowing employees to participate, it's 30% of the cost of coverage in which they're enrolled. We're assuming they're only enrolled in self-only or individual coverage. You're only allowed to have an incentive that's 30% of the amount of family coverage or employee plus spouse coverage if the possibility to benefit from the program is extended to the employee's spouse. I would also say children before the GENE rule, but you know, while it's certainly possible for children to participate in some capacity, we know this is going to be a sensitive issue, at least as these rules are rolled out. And so you'd have to think really carefully if you're going to offer a benefit that's 30% of family coverage, and you're going to make that benefit contingent on some type of participation by an employee's child. What exactly that participation looks like. You can certainly offer the benefit, but you need to think about you know, what you're going to ask of an employee's child.
Great, thank you. Is there evidence to argue most companies would benefit most from attaching wellness programs to health insurance versus keeping them separate, or is there no correlation?
I don't know if Dr. Noeldner has a sort of an observation or empirical evidence about it. We have employers who have them both ways. So, for instance, some employers want programs to be broadly available to all employees, regardless of whether employees participate in the employer's group health plan, and they do, you know, lunch and learn type events about nutrition, and they do walking programs and those sorts of things that are broadly available, and basically provide rewards based on their employees' participation, and find that that's an effective way to engage their employees. Conversely, we have other clients and have anecdotally heard of other programs where they want to be more aggressive about a particular concern they have for their employee population. Let's say it's weight, cholesterol, stress, tobacco use is a big one. And because their program design is more aggressive around, let's say, tobacco cessation, they may really benefit from integrating that as a term of their, integrating that program as a term of their group health plan, and therefore it's baked into the plan. The rewards are easy to track because they can be provided as premium reductions. And only really premium reductions, and they may have some additional protection from the bona fide benefit plan safe harbor, which right now is up in the air. But you know, Flambeau, the company at issue in the litigation, won the first round and had the EEOC's claims against it dismissed. So it really depends on the employer's circumstances.
And I guess I would add, aside from the legal issues that Chris can, of course, speak to better than I, some of the other things, first, let me just say that I don't think that there's any one absolutely right approach for every organization, and I think Christopher just articulated why in some way. Some of the considerations that organizations have around which vehicle to use, whether it be health plan, premium differentials, or contributions to an HSA, HRA, is that they, let's talk about premium differentials as probably the prime example. In a model like that, the dollars that you're actually giving to people could be considered to be found from those who don't participate, and so it's a way to not have to come up with a big pot of money for incentives that would be given as a cash or cash equivalent to every participant. And that so that sometimes makes it attractive and the only affordable way that some organizations can put a meaningful incentive in place. So certainly a consideration for some.
Wonderful, thank you so much. I think we are essentially out of time, so I'll just remind our attendees that they'll be getting a survey at the end of the broadcast. We encourage you to give us feedback on today's broadcast and future broadcasts. I want to thank both of our presenters again very much for their sharing their expertise and knowledge with us today, and remind you also that a recording of today's webcast and the slides will be available on the member website. If you have any questions, you can certainly filter them through me or contact our presenters directly. So thank you very, very much, and have a wonderful afternoon. Bye.